grand rounds. Thank you all for joining us. And it's a real privilege today to welcome our new chair of pathology at Yale and Yale New Haven Health. Dr. Chen Liu is the Anthony N. Brady Professor of Pathology, who joined us on March 1st. So really right into the thick of it did he arrive. And Chen has really been in the short time he's been here, has become a incredibly welcome collaborator to all of us, particularly in his efforts to champion the testing efforts that were essential in our response to COVID. Chen received his training in China, received his postgraduate training at Peking Union Medical College, his PhD in pathology at the University of Pennsylvania, and more recently had served as the chair of pathology, immunology, and laboratory medicine, as well as the chair for the Center of Dermatology at the Robert Wood Johnson Medical School in New Jersey. Chen's career has been focused on the work in viral hepatitis, liver cancer, immunotherapy, graft versus host disease, as well as cancer epigenetics, where he's made important contributions in all of these areas, really understanding mechanisms of carcinogenesis, defining new cancer biomarkers, and equally importantly, developing new therapeutic approaches. And we're really so privileged to have Chen not only as the new chair, but as a member of our cancer center. And this really gives us, I think, really great additional expertise and strength among the talent we have here. So Chen, thank you, welcome, and looking forward to your talk.
Okay, thank you very much, Charlie, for the nice introduction, and also more importantly, thank you for the opportunity to present this talk. And I hope this will be an opportunity for me to get to know you all virtually, but unfortunately I cannot make a round to visit you in person. So I think we try to get the best out of it. So I think I just briefly, so I am a liver GI pathologist. So I'm actually practicing, the clinical service. And also, I'm also a pretty good mouse pathologist in general. So I think basically I served as a sort of expert consultant for all the mouse knockout, knock-in model for phenotype determination. Just keep that in mind. If you have any, need, I'm more than happy to collaborate. So as it's been my interest to see how to correlate mouse pathology with the human pathology and trying to make the model. We always say, we use the animal to build a model, but the question is a model of what? Model for human disease. So that's why this is kind of background. I'm looking forward to work with you. You can see from those presentation, I tell you, we have built a lot of material for all of for us to share with you. A lot of tissues, cells, animal models that we want to share with you. All right. So today, I would just talk one of the main research project in my laboratory, which is sort of how to develop a more effective immunotherapy for hepatocellular carcinoma. Okay, so good. So as you know, hepatocellular carcinoma is a very deadly disease. It's actually relatively common. We have almost 600,000 new cases a year globally. In contrast to many other type of cancers, hepatocellular carcinoma's etiology is relatively well known. For instance, you can see it's almost 80% of those cases are caused by two viruses, hepatitis B and hepatitis C viruses. And then the others, with a toxin, alcohol, or some recently fatty liver disease, and some metabolic liver disease, all contributed to the etiology of hepatocellular carcinoma. I think one thing in common is in majority of the cases, and there is long-standing chronic liver disease, and then develop chronic, hepatitis, and also cirrhosis, which is almost like a precancerous condition, and then become hepatocellular carcinoma. Because of this unique etiology and the pathogenesis, there are at least two things we can think about. One is the best way to eliminate this, cancer is it is eliminated the etiology. So in this case, if you can eliminate hepatitis B, hepatitis C, we pretty much eliminated 80% of the cancer. So hepatitis B vaccine has been practiced over multiple decades. I think the data is already show because of the widespread of vaccination against hepatitis B, the incidence of liver cancer indeed has seen trending down in the hepatitis B prevalent regions. And so the other thing is, question is, because of its long-standing process for from the initial liver insult to the cancer formation, it's usually we're talking about 20 to 30 years. And then we do have very high-risk population. So we know this high-risk population, so this provide a window opportunity for us to develop biomarkers or some therapeutic interventions. In other words, we can identify the underlying pathogenesis, and hopefully we can identify targets and to intervene or prevent or treat the hepatocellular carcinoma. So currently, unfortunately, the liver cancer therapy is really behind to many of other solid tumors. We did not have really big progress, for the hepatocellular carcinoma therapy, and there is absolutely unmet need in this cancer. So liver transplantation can be considered as a curative therapy if we can identify the tumor earlier, and also there is a liver available for the patients. Those can be considered cure. And the surgical resection has been performed, but the recurrence is it's almost in 70% of patients after the surgical resection. So overall, with the typical therapy currently, the 3-year survival is still less than 20%. And in about 10 years ago, the one first therapy was approved, which is sorafenib. Sorafenib is a tyrosine kinase inhibitor, and so that can only show the moderate effect in a small number of patients. And only the past 2 or 3 years, we have seen another momentum, which is the checkpoint inhibitors, role in the treatment of hepatocellular carcinoma. So we can talk a little bit more about the checkpoint inhibitors in the next few slides. So first of all, this is the tyrosine kinase currently being tried and approved or tested in hepatocellular carcinoma, sorafenib, regorafenib, which is basically another version of sorafenib, and then the other tools are also tested. But all of those tyrosine kinases, it's really more broad inhibitors rather than specific target. So it's been believed that those inhibitors inhibits kinase activity, and in consequence, suppress tumor vascularization or really play some sort of anti-angiogenesis effect. So we have actually also shown that for example, sorafenib can also interfere the mitochondria in hepatocellular carcinoma. In other words, there are probably multiple mechanisms for the tyrosine kinase mechanism of action for hepatocellular carcinoma. And I would like to show you this slide, and this is the slide made by Sharma and Allison. So this tell you how the therapy you can see is the chemotherapy. This is for cancer as a whole. So one thing you can see is the immunotherapy, which represented by this green line, is certainly is superior to any other sort of monotherapy. However, if you combine the checkpoint therapy with more targeted, genomically targeted agent, you can see dramatic improvement. So that's probably why, the immunotherapy attracts such attention. I think, as you know, over the past decade, we have been talking a lot about immunotherapy, and most particularly the clinical application of an immune checkpoint inhibitor really created this momentum for cancer therapy. All right, so with that background, we'll see you have to look at the liver. So what is the unique aspect, unique aspect of hepatocellular carcinoma? So this, I have to say, we have not much understanding on the overall immunology or immunobiology of the liver as well as the hepatocellular carcinoma. So liver has been considered as an immunologically tolerant organ. And that means, there are data shows all the humans' active T cells actually are eliminated in liver. In other words, liver is so very, very well protected. And then the other thing in the liver, there are a lot of antigen presenting cells. However, there are data shows most of the antigen presenting cells actually induce tolerogenic phenotype rather than activate the cellular immunity. And as I mentioned earlier, majority of the hepatocellular carcinoma is actually arising from the background of a chronic viral infection, hepatitis B, hepatitis C. So this has been known, or it has been extensively studied. Long-standing chronic viral infection actually rendering T cell exhaustion. So this is another challenge we have to think about when we're talking about how to develop more effective immunotherapy for hepatocellular carcinoma. So also HCC, has a very higher expression of PD-L1. PD-L1 is a ligand for PD-1. So those engagement actually suppress the activated, anti-tumor T cells. That's probably why this is how you use, you can actually use checkpoint inhibitor to block this interaction between PD-L1 and PD-1. The other aspect is there are many regulatory T cells in hepatocellular carcinoma. So we have shown, there's a high number of regulatory T cell as well as myeloid-derived, tumors, suppressive T cell, MDSCs. So those are the challenges, we have to, consider. And then, when put all this thing together, probably we need to think about a multiple strategy to really develop a more effective, immunotherapy for HCC. And, things more broadly currently in clinical application also has been, very exciting is a checkpoint inhibitor. You see, the impact of a checkpoint inhibitor really is act on multiple type of the immune, regulation, most specifically blocking PD-1, PD-L1, interaction. So the other things you can think about is to really eliminate, also at least inhibit regulatory T cell in the cancer. And the other is more, exciting, that's what I'm going to talk about a little bit more, is adoptive cell transfer therapy. For those adoptive, cell transfer therapy, we really can think about two things. One is non-antigen specific, autologous cells, for example, NK cells or tumor infiltrating lymphocytes. And then the other is actually another modified version of adoptive cell transfer therapy is engineering T cells. So this will be the, CAR T, cells. Those I will spend a little bit of time too. Another thing is to think about if we can identify tumor-specific antigens, we can think about is to develop a therapeutic vaccine. So actually, this is probably more ideal because you will be able to induce tumor-specific immunity. So we had done some work in this area, so I will show you what we have found. Okay, this is just the introductory slide, for what we are, for this audience, you probably all very well know what, sort of immune checkpoint inhibitor therapy. For example, is really blocking these two inhibitory molecules, PD-L1 and the CTLA-4. So those are inhibitory. So basically, we develop all kinds of therapeutics called checkpoint inhibitors, is blocking those two inhibitory, pathways, and as a way to activate the T cells. So for liver cancer, as you know, at least right now, I mean, this, the update is almost, I say this is updated today, maybe it will be changed, very soon. as well, because for right now, we have at least 3 FDA-approved checkpoint inhibitor is one, and pembro, nivo, and the other one is against the CTLA is ipilimumab. So those are 3 FDA-approved. And certainly there are many in the pipeline. You see how busy this slide is. You see those are the current clinical trials registered with, clinicaltrial.gov, and those are the phase 3 trials with all kinds of checkpoint inhibitors. So you will notice that most of the trials actually is looking at the combination therapy, particularly with tyrosine kinase inhibitor, also VEGF inhibitors, as well as combined with some local regional therapy or surgical resection. So you can see the estimated releasing date, completion date will be in the next year or two. We're going to see a lot about the results related to checkpoint inhibitors for HCC. So this is really the exciting part of for the in this field right now. So now let me try to talk about a little bit more the other approach, which is in active investigation by quite a number of groups in the world. So which is really the adoptive cell transfer immunotherapy. So for those, this concept wasn't really new. So the first tumor infiltrating lymphocyte therapy, as you may know, it was developed decades ago by Rosenberg at NCI. So in that case, he isolated TIL, called tumor infiltrating lymphocyte, isolated TIL from melanoma patients and reinfuse those cells back to the patients. But now, over the past few years, more and more evidence point out the really efficacy of this sort of therapy. And also more recently, you can actually, culture certain cells in in vitro, and stimulate certain T cells and to induce so-called cytotoxic T cells, and then refuse those cells back to cancer patients. And another is really the innate immune response arm, which is NK cells. By definition, NK cells, it's the main biological function is really as a surveillance, plays a surveillance role in the body and to check out to kill the tumor cells. So there are a lot of attention on NK cells as well. So I will share a little bit of data we have written down with NK cells, and of course there are excitement coming from the engineered autologous T cells, which is CAR T. Okay? So those are we'll just talk about. So let's first to look at this how we can induce more cancer-specific immunity. All right. So in this case, we probably want to find out, is there any tumor antigen, or is there any specific tumor antigen in hepatocellular carcinoma? So indeed, over the years, we know alpha-fetoprotein is one of the first tumor antigen associated with hepatocellular carcinoma. However, with multiple different groups of trying to use alpha-fetoprotein for immunotherapy, the results are really mixed because maybe the alpha-fetoprotein is really highly expressed in embryogenesis, and also in some other highly proliferating cells. So it's created a lot of challenge. So this slide showed you over the years, and actually for hepatocellular carcinoma, fortunately we did find a very good tumor antigen called the glypican-3. You can see this is glypican-3 expression, fairly specifically expressing hepatocellular carcinoma. So what is glypican-3? So this glypican-3 is X, it's on the X chromosome. So it's highly expressed during embryogenesis and then stop, in the adult tissue, and then overexpress in more than 90% of hepatocellular carcinoma. So unfortunately, we really do not understand the role of glypican-3 at the moment. I mean, I had 2 graduate students had dedicated their thesis trying to figure out what is the biological role of glypican-3. Up to this point, we have say it looks like the glypican-3 somehow interact with other growth factor and to create a microenvironment on the cell surface and to direct the downstream signaling to regular cell growth. Interestingly, glypican-3, there is a genetic, like a genetic syndrome, which is the Simpson-Golobi, Bihomo syndrome. I have never seen a patient like this. It's only rated from textbook. So this is a syndrome actually is the loss of function of glypican-3. So, and you can see it's, overall, if you look at the syndrome, it looks like the deletion of glypican-3 creates some sort of overgrowth. All right. So this, that has been confirmed in the knockout mice. Look at this knockout mice, the embryo is just much larger than the wild type. So this is almost the antithesis for us to think about if the glypican-3 can somehow act as, it looks like a tumor antigen to promote cancer formation, but somehow during development, it's actually glypican-3 seems to act as a suppressive function and to check the development, during the embryogenesis. And then if you look at the overall expression pattern of glypican-3, there's really, 3 major organs express glypican-3. Guess what? The highest one actually is the placenta. Right, so the placenta has the highest expression of glypican-3. So that's why I think just last month I went to see Dr. Harvey Clayman, who is really the leading expert in placenta here at Yale. And I talked with him. So I said, let's figure out what is this glypican-3's role in placenta. Right. Anyway, the other organ is the fetal liver. You see, they express, and then also fetal lung. And then in adult tissue, fetal lung is completely zero expression. Adult liver, like a mature liver tissue, normally they do not express glypican-3, but however, it's expressed in hepatocellular carcinoma. So here is the immunohistochemistry. You see all the, the cancer cells express those things, the proteins on the cell membrane. And actually, this is one of the marker, for pathologists, for liver pathologists. Sometimes when we question about whether this is cancer or not, we tend to do immunohistochemistry to confirm, to help us to make a diagnosis of hepatocellular carcinoma. All right, so this is also we checked with all the different cancer cell lines, tissues, and both at mouse and human. So interestingly, the mouse hepatocellular carcinoma does not express glypican-3, and only in the humans, all the different cell lines we have checked, and they overexpress glypican-3. The normal hepatocytes, does not express. So this is because of the mouse hepatocellular carcinoma does not express glypican-3, actually create an advantage for us to create some model to study, the potential immunotherapy, because when we talk about we want to do immunotherapy, we have to create a model and see how we can, test some of our ideas. So this is just the last, sort of the last slide to demonstrate the glypican-3, expression and its role in, in hepatocellular carcinoma. You can see so here is, almost exclusively expressed in HCC. And at the same time, you can see its correlation, it seems to be correlated with worse prognosis. So now, as I mentioned, let's turn to see how we build this model. Because we have, over the years, long ago, we built this model with this biopsy mice, totally immunocompetent. And then we have this hepatocellular carcinoma cell line, originally derived from biopsy mice. So as I mentioned earlier, so this cell line does not express any glypican-3. So what we did is to overexpress human glypican-3 in the mouse cell lines, and then you inoculate to this mice, and to see, whether we can have a model to test the, anti-tumor immunity. So this is, just a slide to show you. Here, for example, whenever you introduce this cell line to the biopsy mice, you see this is a wild type spleen, and then this is the tumor-bearing mouse spleen. This is about significantly enlarged, sometimes up to between 3 to 5-fold. So it's indicating that indeed the biopsy mice will see this foreign hepatocellular carcinoma as a foreign and somehow trying to mount immune response. But at the end, the tumor wins, because within 2 or 3 weeks, there is big tumor produced either when we do the sub-Q injection or we do the also topic liver injection, you can quickly develop this HCC in the biopsy mice. And then we look at what's the cells in the biopsy. Certainly we have all the different type of T cells, B cells, most of the T cells. But actually, if you will refer the phenotype of those cells, most of the, actually there is a significant regulatory T cell components and also MDSC components. So indicating, so in this mouse model, indeed there is an immune suppressive phenotype. And so that's why the tumor wins and to produce the cell. So we think this probably is a very good model for us to look how we can develop a model to test some of the ideas we wanted to test. For example, one is a tumor vaccine. The other is we want to also think about how to manipulate the different immune system and to check, see if we can have some more effective anti-tumor immunity. So first, as I mentioned, the glypican-3, is highly expressed tumors, specific antigen. So when then we just go in the traditional method, you just say, okay, we will just recreate this protein and trying to build recombinant protein both from bacteria, from yeast, and then use the protein as a antigen to immune those mice. So this data show you, just to show you after we immunize those mice, and then we check, we did not really see any significant changes in terms of tumor size before and after vaccination. And then we checked also, cellular immunity and the humoral immunity, and overall, the conclusion from that is we tried multiple times. If we just inject glypican-3 to the mice, we did not really create any anti-tumor immunity in this, at least in this mouse model. And then we say, then we check the tumor, we did not really see any tumor infiltrating lymphocytes as well. So then we just test this idea to see how about, we think a different approach. So one approach we feel is maybe we should think about how to allow the glypican-3 get to the real, the immune organ in case like go to the spleen or go to the lymph node. So one idea we did, try, at that time thought about it is, how about we conjugate glypican-3 with the lymphocytes? So using this, chemical, I do not try to pronounce it, it's called SMCC, and use this conjugate. Basically, we conjugated the glypican-3 protein with the lymphocytes. So the hypothesis was to use, if the lymphocytes carry this protein, the antigen, and the lymphocytes has this natural homing capability, and they will go to that right immune organ, maybe that it will accept, to initiate anti-tumor immunity. So actually that's, indeed it was the case. So this is just to show you, we conjugated the lymphocytes with, with the protein, and then we, inject back those lymphocytes, to the mice, and then we look at the tumor. You can see the conjugated one significantly suppress the tumor growth. And this is a different treatment protocol. You can see it's really time dependent. And so this is a very, exciting. And then we say, okay, let's check what's, all the cells and the different components. So this just to show you, we checked that this is the ileus spot. Definitely compared to the control, you can see a lot of activated T cells. More importantly, exciting is after this conjugation, actually we can see the lymphocytes actually infiltrated into the tumor. So this is what we believe, this is probably why we, this sort of vaccination approach worked. So again, this is just another different data, to show you, how this, this is just demonstrated. Indeed, all those effects we have seen is related to the conjugation between the lymphocytes and the glypican-3 protein. So for that, this is. But anyways, we'll summarize this data. So we think, later on we actually purified. Initially we just used the total lymphocytes, but now actually we tested is just isolated CD3 cells and it was a T cell. So this work is ongoing. So basically, it's what our working model, our working hypothesis. We want to continue to try that. Is we are using T cell as a carrier for tumor therapeutic vaccine delivery. So this is when we are testing this in hepatocellular carcinoma. I think there's a possibility that those can be become a sort of a platform for T cell, for therapeutic vaccination approach. So this is the work ongoing in my laboratory. Now, let me share with you some of the other things which is more also cellular therapy related, and this one is the CAR T. So we did develop, develop this glypican-3 CAR T cells. So this is just a diagram to show you we use the lentiviral vector and then basically created this GPC3 CAR T cells. So right now we created both in the T cell, you purify the T cells, and also we created this platform using NK cells, which I will talk a little bit more in the next few minutes. So those has been shown. This is another diagram. The other group also developed this, glypican-3 CAR T, and then they use a different, region. They're focusing on the C terminal of the protein, and then we decided to focusing on the N terminal because the N terminal is our side of the cell membrane. We believe, the N terminal may have better access. So this is our CAR T, construct, and we basically this is so-called a third generation, platform. We developed both in the lentivirus as well in collaboration with another faculty at Rutgers, Dongfang Liu. So he has a retrovirus platform. We actually work together and also made this construct in the retrovirus platform as well. So then, test this CAR T in vitro. So it seems to work very well. And also we tested in the animals, this is just show you different cancer cell lines. And this HU1545 is immortalized hepatocellular cell, immortalized liver cell lines developed in my laboratory. So to basically serve as a control, you can see, so the target, because these cells, does not have glypican-3. The 1545 cells does not have a glypican-3, so there's no target. And the others, the commonly used hepatocellular carcinoma cell line, HUS7 cells, and also HepG2 cells to show significant killing effect. So this is in cell culture, and then we also decided to introduce it into animals. And indeed, we treated those animals, this tumor volume, compared to the controls, and the CAR T, glypican-3 CAR T indeed show very effective, very effective, and also last almost 2 months. This is really, exciting, and I think we pretty much, feel very confident in this construct. But now the thing is, you see, certainly eventually we needed to bring this to human trial and to see if this construct will be actually showing effectiveness in humans. So that's certainly, need a lot of effort and also some other, funding and to get this done. So this is really, exciting. And also we tested this similar CAR T using PDX mouse model, because to develop that, that's another thing I mentioned earlier. We are very happy to share with people, working on hepatocellular carcinoma, also pancreatic cancers as well. But we build multiple PDX mice, over the years. Not only we have the PDX mice, we also have the corresponding cell lines. So, for both liver cancer, pancreatic cancer, and we also have other tumors, PDX as well. So this is just that allow us in future to develop more, I would say precision of personal immunotherapy, because this way we can see if we can derive some more specific antigen and from this particular patient, and then from that platform to build a specific CAR T for patients. Certainly that will be what, the future endeavor for that. All right, so the last section of my talk, is just want to share, let's turn attention to the, the innate immune cells, which is the NK cells in HCC. So you probably ask why we're so interested in NK cell. If you look at the human body, the organ contains the highest number of NK cells is the liver. If you look at the liver, almost 2% of the liver nucleated cells are NK cells. I mean, you probably say it's very, surprised. Actually, it's, but what does NK cell do in liver is very I would say to say minimum is poorly understood. All right. So, however, over the years, you see back to even 1990s, people already shown that if you test the NK cells from the hepatocellular carcinoma compared to the non-tumor cells, they show the NK cells had this dysfunctional in terms of they have a light killing effect. And this also, like in 2013, another group also reported this. But very few literature, to really show, I would say strong evidence say what is the NK cells function in hepatocellular carcinoma. All right. So as I mentioned, it's such a big you have more NK cells than many other lymphocytes in the liver. So that question is how we can find out what the NK cells will do in those cells. The others, the NK cells, some people also just relatively recently reported, if you expand the NK cells and then infuse back in the mouse model, actually expanded or the NK cells does possess anti-tumor effect, activity in mouse models. So this will be like an in vivo, experiment. So it just indicate, NK cells, after expansion, they still maintain the anti-tumor effect, activity. I think that's very critical for us to talk about. If we ever wanted to, make NK cell to be a therapeutic platform, we have to make sure the expanded NK cells would have that function. Right. This is, a couple of years ago, and this is also in collaboration with another faculty, Dongfang in Rutgers. And so we decided to let's start, some of the basics of NK cells in HCC. So what the platform we use is, we had a liver transplant program there. So we basically, for any HCC transplant liver, so we'll get the tumor, and then we will, isolate the NK cells from the tumor, and isolated, from the adjacent, zone, we call the adjacent zone from the, the liver tissue, and also isolate the NK cells from the tumor, like we say, non-tumor distance, at least 5 centimeters away from the tumor, and we isolated all those NK cells, and then we expanded those NK cells. And then what we do, and at the same time, we get the blood, patients' peripheral blood NK cells, and then to compare with different others, at least those 4 groups, and to see what's the function or what's the basics on the NK cells. So what, after we did that, so we did quite a number of patients, as the most common transplant liver is hepatitis, C liver, and also the other is alcohol-induced, cirrhosis. And so that's where we literally focusing on HCV liver and also alcohol liver. So with that, we'll do the functional assay, and then we did a lot of RNA-seq, trying to see if there are any changes in those cells, and then later on do quantitative PCR to determine certain specific genes. So this, all right, okay. To make a long story short, because of time issue, I will not get into the killing assay. So basically, what we find is that there are significant difference between all the NK cells we isolated from different liver. For that matter, interestingly enough, HCV-related liver NK cells and the alcohol, related liver cancer, they are also different in terms of function. They have less killing activity in alcohol, but interestingly, they have even higher killing activity in HCV, which is really surprising to us compared, So with that, as I mentioned, we did RNA-seq, and then got all the data, but we still have sitting on a large amount of data still waiting to be analyzed. But at least at the moment, I can share, this is really fairly recent, just a few months ago, we actually identified the CD62L, of course, the cell or L selected. So this has been really significant change, between all those different NK cells. So here the summary, we can see relatively, for whatever reason, in NK cells isolated from HCV-related HCC, so HCV-related HCC, you actually have a higher expression of, selectin. And however, in the alcohol-related NK, so you have a lower expression. So this will be I would say, put all together as average, as a baseline. So it's really interesting, how this dichotomy, which by itself may not be very surprising, because the difference is if you look at the histology between the cancers arising from HCV and the cancers arising from alcohol, the big difference is in the HCV cancer or background liver as well, you always have the inflammatory activity going on. In other words, you have the inflammatory milieu within those livers, which in alcohol-induced liver cancer or liver cirrhosis, you have minimum inflammatory activity. So I think this is sort of exciting. We are thinking about is right now is we need to further examine what's the actual role of the CD62 or selecting the role in these NK cells. Particularly is we wanted to see if the inflammatory thing or hepatitis, virus itself contribute that to that difference. So this is our model right now. So this is the working model. We are actively pursuing that. As I mentioned, this was summarized with all our current data with the NK cells. What do you see? The NK cell higher expressing one, actually they are higher killing capacity. So those are mainly from the HCV stimulated HCC, right? That's very interesting. And however, in contrast, the alcohol-induced HCC, they have a lower CD62 and also lower killing capacity. So that's really, allow us to think about if we ever, the next step in the future, if we develop a therapy, maybe this is where, if we understand more about the role of LCD, the CD62, and we, potentially can think about is, how we can turn this CD62, lower expression one, and to get them to be more, active against the HCC in the alcohol setting. Because for the HCV, however, I don't think further stimulation by CD62 will be good idea, because if they already have pretty strong HCV, put this way, they already have higher NK cell activity and also higher CD62 expression as well. So we may have to think about what other strategies for HCV induced HCC. So this is a working hypothesis. As I mentioned, we need to do more cases and then to see if we can find something more specific and to treat this HCC. And so the bottom line is, I think more and more we see this trend, which is the tumor heterogeneity. So we cannot lump sum of the HCC altogether. Apparently, for HCC, different etiology, it seems like to have very different, biology. So when we thinking about developing therapeutic strategy, we have to really think about, take that into our consideration. And furthermore, as I said, mentioned those to testing that model, we think it might be the HCV itself will somehow engage the NK cells. So this is our current, very preliminary result here. We basically culture the HCV positive because we can grow hepatitis C in those tumor cells, and then to co-stimulate, or we call it priming the NK cells. In this case, we can just use another, the NK cells and testing the target cell line, K562 cell lines. So the cell you can clearly see after coaching. In other words, it's the priming the NK cells with hepatitis C indeed induce the NK cell functionality. But now the question come to the point, say even you have a stronger NK killing activity in HCV-induced hepatocellular carcinoma, somehow the HCC is still prevail. So in other words, though maybe this is by itself is not enough, or maybe because remember what we so far tested is all in the in vitro isolated condition. So this is really coming to the point that there may be some other immune suppressive phenotype in the microenvironment, which even in vitro, the NK cells maintain their endogenous, anti-tumor activity. But however, in the immune suppressive microenvironment, those cells simply just cannot function. So that's really tell us, when we deal with HCCs causing by hepatitis C virus versus, like a non-alcohol, versus the alcohol caused the HCC, we have to think about differently. So this is really, just to give this as an idea along this, and we are actively investigating the possibilities. All right, so I think my time is almost up, and I think this will be the summary, and I will say, you can see, this from both, patients and the mice. So there is an immune response in HCC. That's good sign. That means that there is engagement between the tumor and then the endogenous immune system. So this created an opportunity for us to develop, better therapy. So it seems like the immune suppressive cells are dominant in HCC patients, and both in patients and also animal models. And we demonstrate, from our own study, also many other people's study also shown the tumor vaccination of specifically the therapeutic vaccine and those CAR T cells or NK cells are indeed promising, therapy. And as I mentioned in the last section about the NK cells, we see the differences between the HCV-induced HCC and the alcohol-induced HCC really tell us we have to think about a personalized immunotherapy approach. We have to really see if we can, separate those cancers with, according to their etiology, and then develop, more effective therapy accordingly. So now the challenges, it's not easy to get this done, but I think many are really, not just, confined within, liver cancer. Actually, you can have this, probably in multi other cancers as well. I think that's the one area we all need to think about how to do this. So certainly biomarker for guiding therapy is absolutely lacking for immunotherapy especially, but we are making inroad right now, for example, total tumor antigen burden, like a microsatellite instability, as has been demonstrated, as a predictive marker for better effective therapy for checkpoint inhibitor. So that's the right direction. But we still need to think about more specific biomarkers for different cancers and to see how to get therapy. And then obviously we almost know there will be some sort of tumor resistance coming up. So that's where, we need to pay attention or at least consider the possibility of the development of resistance and its potential mechanism. The cost is high, particularly when we think about personalized immunotherapy. We all know that. Tumor heterogeneity, really, as you mentioned as well. But and the other is really, there is a very active field right now is targeting new antigens. The new antigen formation, because that you can induce new antigens through irradiation therapy or some tumor, like a regional, local regional therapy for hepatocellular carcinoma. Either injecting chemotherapy agents or radiation, create a new antigens. So those new antigens probably will be able to, to serve as a target for us to develop, more like a potentially effective, immunotherapy approach. Okay, so with that, I will say, I thank the people who are working in my lab, especially I have this MD, PhD student, graduate student, Aditya, so who did all this NK cell work, and Frank, and Lei Yang, who's a postdoc, who did all the tumor vaccine work. So I have a lot of collaborators to thanks from, my, really prior institution, University of Florida, and also Rutgers University, and especially I thank Dongfang Liu, who is actually, developed, shared his expertise with us on NK cells, and also the, the retroviral vector system, to build a better effective CAR T. And also my long-term collaborator at the Mayo Clinic, and again, saying, the funding agency for support our work over the years. So I will stop there and welcome questions, ideas from the audience. Thank you all for your attention.
Chen, thank you, and thank you for a terrific talk, as well as the work you're doing in this very challenging malignancy. And folks should submit their questions on the chat button. But let me, if I may start.
Yeah, please.
Yes, because you very nicely identify the potential differences in immune response between alcohol-associated malignancies alcohol-associated malignancies as opposed to viral. Where, given the rise in the role of non-alcoholic steatohepatitis, NASH, in HCC pathogenesis, where do you see that aligning compared to the models you've now been studying?
Yeah. So that's the thing. There are two issues here. All right. So yes, NASH associated hepatocellular carcinoma, but based on epidemiology study has seen the rising incidence. However, in practice, we've seen very little of those cases, because of I think that's the thing, because, we're using the liver transplant as our model, to get those, that's where we got the tissue. I think this is common. We just do not have a lot of cases, actually human tissue cases, I would say HCC arising from the NASH patients to study it in detail. But there are, but each center, they will have really a few in the cases. It's very hard to do the study. Second point is, if you look at, in terms you look at the histology, so the alcohol related, cirrhosis probably will, have more resemblance to the NASH associated cirrhosis or carcinogenesis, because they both contribute, for example, how alcohol induce, cirrhosis and hepatocellular carcinoma, probably by messing up the metabolic pathway within the liver, right? So that's, and same way, NASH related thing, it is basically part of the metabolic syndrome. So I would think if you want me to guess, I assume those probably more or less related to the, to the alcohol-induced HCC, which is less inflammation. So that's the key difference. If for pathology, if you look at the tissue, you have very little inflammation in the NASH or alcohol-related liver injury. But hepatitis C, you always have this ongoing chronic inflammation. I think that's the key difference. I mean, it was sort of a surprise was, or may not be a good surprise, because when actually see the NK cells behave very differently in those two groups. Interesting question. We don't know. So, complete, we don't completely know that yet.
Yeah, so a number of our members of our audience have submitted questions. I'll start. Marcus Bosenberg is asking, have you considered making CAR T to either hepatitis B virus or hepatitis C virus antigens expressed on the cell surface?
No, we haven't, because the reason we haven't is we really worry about that kind of therapy. As a matter of fact, if you look at the viral distribution in the liver, you have more viral expression in the non-tumor cells than tumor cells. For example, you stain the liver, let's use an example like hepatitis B. If you look at the hepatitis B, antigen expression in both the tumor tissue and the non-tumor tissue, you tend to have a higher expression in the non-tumor liver tissue. So we really worry about it. You created this type of a target, you probably wipe out the liver instead of killing the tumor cell. So I don't see those are really, but again, assumption, as well, that's part of that's probably part of the reason we haven't really seen people reporting or making those hepatitis B or C, CAR T yet.
Yes, thank you. So a question from Dampat Jain. Are the T cell infiltrating cells in the tumor, are they different from the T cells in the adjacent hepatitis C infected liver? And related to that, what would be the effect of immune checkpoint therapy on the background liver vis-a-vis the tumor if they are different?
Right. So that's great point. Let's see first. For the first part. So we did not really look at the overall generic T infiltrating lymphocytes. So we basically we did not examine the whole T cells compare the tumor and the non-tumor liver. So we're really focusing on the NK cells, because we decided just focusing on NK cells, and for different for a number of reasons I mentioned. So we don't know the total T cell difference between tumor and the surrounding liver in Hep C and also in alcohol cirrhosis. So that's one thing. The second, question is, well, whether or not, put it this way, the inflammation, driven T cell, whether, you will be able to see, in the inflammatory setting and how those cells behave. So we really don't know at this point.
Thank you. question from Mandar Muzumdar asking, given the differences in tumor cell biology and immune microenvironment between HCC of different etiologies, how do you think about modeling these etiologies in animals to more reliably test immunotherapeutic approaches?
Yeah, that's a great point. But I think at this moment, I don't see we have a good model to test that. Particularly, if you look at the mouse model, I mean, we also created, hepatitis C transgenic mice, but we never been able to recapitulate the similar the similar pathogenesis. Yes, if you have a hepatitis C, like a transgenic mice, but somehow you do not have the inflammation you would otherwise see in the human model. The reason is that when you build a transgenic mice, you basically create this immune tolerance for the antigen. For example, so that means the mice, the host, will treat the transgene you put in and as a natural, own protein. So we never been able to initiate those kind of inflammatory model. The other model is your chemical induced model, to look at the carcinogenesis. It's really not the same at all, because in those cases you have more liver damage rather than actually inflammation driven. So for that question, I don't think we have a really good model to look at the immune checkpoint inhibitor. So for that matter, all right. So the one we developed, the BOP-C mice, it would be good to look at the immune checkpoint inhibitor. But again, in that setting, the difference is there is no hepatitis C infection in that system. We actually trying to get a hepatitis C virus genome in those BOP-C HCC and trying to do that. But for some reason, we still cannot recapitulate the inflammatory response in that system. So again, just like Dan asked early on, so for those, differences, whether you have inflammatory changes in HCC or less inflammatory changes in alcohol-induced HCC, when you use checkpoint inhibitor, how they behave, we don't know. For whatever the reason, if you look at the clinical trial they conducted, they never teased this out. Because actually, I have been serving as a reviewer when they submit the grant. I say, can you separate this out? Can you say alcohol HCC patient and also HCV patients, when you use a checkpoint inhibitor, do they behave differently or behave the same? I mean, for some, I guess probably, the case number overall, you still have a relative fewer numbers of people with alcohol HCC. I think majority of the patients still is like a HCV or HBV related HCC. I think that's really important, because I think, the checkpoint inhibitor should absolutely consider, and in the setting of natural, I would say the, physiological difference in terms of the, pathobiology, for example, whether or not they have the endogenous inflammatory milieu or microenvironment or not, I think that could make a huge difference. I think this is actually one of the area I would think is we should really look at the difference between the two groups of tumors and when we use the checkpoint inhibitor. That we can probably learn a lot, because one, as I said, almost no inflammation. The others has a lot of inflammation. So yeah, I need to see more data on that.
Yeah. And last question from Jeff Sklar, is GPC3 expressed in cholangiocarcinoma? And what about cells in HCC that show cholangiocarcinoma differentiation as a feature of HCC?
No, it doesn't. Glypican-3 does not express in cholangiocarcinoma. And when with the mixed type tumor, we call it the mixed type tumor. Both you have hepatocellular and the cholangiocarcinoma. In that setting, yes, some of the hepatocellular carcinoma can be stained for glypican-3. So I have to say I think this is, we haven't done that yet. So this is this idea to the audience. So in the literature, they have demonstrated by immunohistochemistry, they have seen like a certain percentage of prostate cancer, breast cancer, colon cancer also express, like if we say between 5 to 10% of those cancers also express glypican-3. All right, so those are in the literature. Those really any doctor type of reports out there. We never look at it ourselves. But for some of anybody, if you are interested in that, maybe you can look into some of those. I mean, it's not surprising if glypican-3 also expressing some tumor cell, because this is just one of those embryogenesis type of protein got re-expressed and in cancer. So just throw this information out there.
Yeah. Well, Chen, thank you. That was really a superb talk, and we're so fortunate now to have you as a member of our cancer center. So welcome, and we look forward